Spirometry is required to make a formal diagnosis of COPD. It's the objective way of determining if airflow limitation is present and whether it's reversible. Airflow limitation that is irreversible or only partially reversible with bronchodilator treatment is the diagnostic feature of COPD. But first, what is spirometry and how do we use it for the diagnosis of COPD? A spirometer is a device that measures the volume of air that's inhaled and exhaled by the lungs. It can also detect the rate of flow measured in liters per second. When you order a pulmonary function test for the diagnosis of COPD or asthma, a technician will use the spirometer to obtain two important values. The first is a forced expiratory volume in 1 second, or FEV1, which measures how much air the patient can exhale in 1 second. The second value is a forced vital capacity, or FVC, which refers to the entire amount of air the patient can forcibly exhale after taking a very deep breath. I went to the pulmonary function lab at my hospital and asked the respiratory therapist to put me through a standard spirometry evaluation for COPD. This is what I learned as she coached me through the process.
You're just checking to see how well you can move your air in and out. So you're going to pinch your nose, breathe normal on the mouthpiece. I'll tell you to take a big breath in nice and deep, and you're going to blast your air out, pushing all that air in one breath. And then I'll tell you to bring your breath back in and you can disconnect. So go ahead and breathe normal here first. Get a nice and easy, normal breathing. Doing good, nice and easy. Just getting your baseline. Okay, get ready. Big breath in deep. Let it flow. Push, keep going, squeeze it out, push. Almost there, keep going, almost there, push. And big breath in deep. Good, come on back. Take off your nose clips.
The spirometry device generates a readout that lists FEV1, FVC, and the ratio of the two. The definition for airflow obstruction for the diagnosis of COPD is a fixed FEV1 to FVC ratio of less than 0.7. In the past, we would measure both a pre- and post-bronchodilator spirometry for all patients. But the guidelines have changed. If there's no airflow obstruction on the initial spirometry evaluation, there is no need to perform any post-bronchodilator spirometry. This adjustment significantly streamlines the process and reduces the need for patients to wait 30 minutes after bronchodilator administration. But if the pre-bronchodilator spirometry results are consistent with airflow obstruction, then COPD is confirmed using post-bronchodilator measurements. Patients with a pre-FEV1 FVC ratio of less than 0.7 and a post-bronchodilator ratio greater than 0.7 may have asthma, or in the presence of COPD risk factors and symptoms, may be at an increased risk for future COPD and should be followed closely. This is a good time to remind you that peak flow measurement is a useful screening tool for COPD, but it has poor specificity and can't reliably replace spirometry for diagnosis. But keep in mind, there are always exceptions. For example, using the 0.7 ratio as a diagnostic threshold for COPD in older patients may lead to overdiagnosis and underdiagnosis in younger patients. Remember that the diagnosis must be in the context of progressive COPD symptoms, as other lung diseases can also present with fixed airflow limitations.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how Medmastery can help you become a great clinician, make sure to watch the About Medmastery video. So thanks for watching, and I hope to see you again soon.